What do we mean when we say our philosophy is caring for life? We're not just referring to our rich history of manufacturing excellent healthcare products, or our commitment to aiding healthcare professionals in their daily work, or our non-stop pursuit of the next effective, trustworthy therapy for chronic kidney disease. Fresenius Kabi knows that caring for life means looking even further. It means caring that Sarah still has enough time in her week to tend to the garden that she's been growing for 28 years, and that Ivana is still able to visit her family in Poland, and about the fact that Chris and Marie have enough energy to look after Tom. They are among the more than 1 million patients who have delayed their dialysis with ketosterol since its registration in 1982. And to them, that's what staying off dialysis actually means. For patients like these, we committed ourselves to create the world's leading therapies, trusted above all others by healthcare professionals. Because our driving factor is to not only support you in preserving your patient's health, but to help them embrace everything that makes their lives worth living.
Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. In this breakout session, let us learn how to teach patients with chronic kidney disease regarding their proper nutrition. This session is presented by Dr. Kristianne Rachel Palanca Medina-Liabres, a practicing nephrologist in Ilocos Norte. She is a graduate of the Nephrology Fellowship Training Program of the University of Santo Tomas Hospital and had her international clinical and research fellowship in critical care nephrology in Seoul National University Bundang Hospital. This session will be moderated by Dr. Harty Yam.
Good morning, fellow members of the healthcare team. First of all, I would like to thank the organizers for the invitation and also to extend my warmest congratulations to Tiger for holding its first virtual postgraduate course. Nutrition is a vast subject comprising of many components of dietary intake, all of which I cannot possibly cover in just an hour or so. In the interest of time, we will be discussing the following. Chronic kidney disease, or CKD, has been attaining importance worldwide because of its major effect on global health, both as a direct cause of morbidity and mortality, and as an important risk factor for cardiovascular disease. CKD is largely preventable and treatable, so it deserves our greater attention. In 2005, the prevalence of CKD in the Philippines was only at 2.6%, meaning over 1.2 million Filipinos had the disease. However, an article published in Lancet in February 2020 estimated over 9 million adult Filipinos already had CKD. This stark increase was also reflected in the United States Renal Disease Data System, which examined international trends in the treatment of end-stage renal disease. ESRD prevalence per million populations steadily increased in 2014 to 15 versus that in 2002 to 2003. Over this period, the largest proportionate increases were observed in the 10 countries listed in this graph, including the Philippines. Data from the Philippine Renal Disease Registry showed a 37% increase in dialysis patients in 2005 compared to 2001. As of 2013, approximately 23,000 patients were undergoing dialysis treatment in the Philippines, amounting to approximately 10 to 15% increase per year. Back to the USRDS data, one of the greatest proportionate increases in the incidence of treated ESRD was recorded in the Philippines. This map shows the geographic variations in the incidence rate of treated ESRD in 2015. Philippines, colored yellow on the map, recorded an incidence rate of 182 treated ESRD patients per million population per year. Given the increasing incidence and high burden of kidney disease, strong emphasis on its prevention should be our priority. CKD has a substantial impact not only on the patient but also on his family and the entire community. Diet is an underused strategy in prevention and in the delay of progression of CKD and in the management of its complications. Diet should therefore be the cornerstone component in the management of chronic kidney disease. Advantages of proper diet in CKD include control of metabolic complications and decreased accumulation of waste products normally excreted by the kidneys, hence delaying the need for dialysis. Even during the earlier stages of CKD, total health expenditures are often high. Since proper diet delays CKD progression, it also then decreases the cost of management. Diet has also been known to enhance length and quality of life of patients. During my fellowship, I did a research on the association of malnutrition and quality of life among 80 hemodialysis patients and found a significant association between nutritional status and all parameters of quality of life. The largest association was noted in the physical composite, and the patients with mild to moderate malnutrition and severe malnutrition were 5 to 7 times and 6.8 times respectively more likely to have abnormal quality of life compared to those who had no signs of malnutrition. The latest DKDOGI guideline on nutrition in CKD has been released in September 2020. The guideline included all patients of CKD of any stage, nephrotic syndrome, maintenance hemodialysis patients, long-term peritoneal dialysis patients, and kidney transplantation patients. Majority of my discussion is based on this guideline. Malnutrition can have an independent effect on the prognosis of patients. To determine whether a nutritional intervention should be started, the nutritional status should be assessed in all patients through screening. In adults with CKD stage 3 to 5B or post-transplantation patients, it is reasonable to consider routine nutrition screening at least biannually to identify those at risk for protein energy wasting. A dietitian can conduct a comprehensive nutrition assessment at least within 90 days of starting dialysis, annually or whenever indicated. This should include appetite, history of dietary intake, body weight, body mass index or BMI, biochemical data, anthropometric measurements, and nutrition-focused physical findings. In adults with CKD stage 1 to 5B or post-transplantation patients, it is reasonable to consider assessing body composition in combination with body weight and BMI at the first visit. This should be done at least monthly in maintenance hemodialysis and peritoneal patients, at least every 3 months in CKD stage 4 to 5 or post-transplantation patients, and at least every 6 months in early CKD. Overall nutrition status and changes should likewise be monitored periodically. Any sudden and unintentional weight change can indicate serious changes in health status. The patient's weight history and comparison to his usual body weight over time may be more reliable in determining the risk for protein energy wasting. But note that a BMI alone is not sufficient for diagnosis unless the BMI is low at less than 18. An ideal and comprehensive nutritional assessment is time-consuming and requires a specialist and is thus often expensive. Among the several nutrition screening mechanisms in clinical practice, only a few are specific to CKD patients. During my residency, I looked at the use of a short nutritional assessment questionnaire or SNAQ to assess nutrition status among 94 hemodialysis patients. Based on the SNAQ scores, 10.6% were moderately malnourished and 13.8% of the patients were severely malnourished. On the other hand, when BMI was used to classify the patients, only 12% of patients were considered underweight. Shown in this slide are several potential mechanisms for diet-related kidney injury. We will be discussing each mechanism in detail. With physiologic nephron loss accelerated by long-term exposure to chronic diseases such as diabetes mellitus and hypertension, the remaining nephrons must work at higher capacity to maintain total GFR. Among persons with already reduced nephron number, high protein intake will lead to further nephron loss via hemodynamic glomerular injury, as it interferes with the kidney's ability to auto-regulate glomerular capillary blood flow by triggering humoral and local mediators that vasodilate the afferent arteriole, leading to increased hydrostatic pressure inside the glomerular capillary and elevated capillary wall tension. This then leads to elevated intraglomerular pressure and glomerular hyperfiltration, eventually resulting to glomerular damage, scarring, and more nephron loss. Distension of glomerular capillaries and heightened capillary wall shear stress will also lead to stretching of mesangial cells, which will stimulate collagen and extracellular matrix production, which will also lead to nephron scarring. Another mechanism is the accumulation of uremic toxins from protein catabolism. These catabolic products are normally cleared by the kidneys. However, when kidney function declines, accumulation of these byproducts will lead to uremic symptoms and progressive organ impairment. The presence of metabolic acidosis also increases protein catabolism, hence more nitrogen-containing waste products are produced. These middle molecules are almost exclusively produced from animal source protein. Correction of metabolic acidosis with alkali decreases protein catabolism, thereby improving the protein balance. Reducing animal protein intake will lead to less uremic toxins and improve renal hemodynamics, hence may reduce clinical symptoms and postpone the need to start maintenance hemodialysis. High animal-based protein and high sodium diet also result in increased endogenous acid production, which is associated with CKD progression. Increased acid load brings about increased capillary glomerular pressure, hyperfiltration, and complement cascade activation. Chronic hyperfiltration is injurious to the kidneys in the long term and contributes to progression of eGFR decline. With nephron loss, the remaining nephrons must increase their generation of bicarbonate by augmenting excretion of ammonium, which results to increased tubular ammonium concentration, which then leads to tubular toxicity and damage. Since acid load is a consequence of protein load, reducing animal protein intake and increasing alkali intake with fruits and vegetables or sodium bicarbonate tablets will lower net endogenous acid production by more than 1/3. Plant-based proteins is metabolized to yield a base, so it decreases endogenous acid production or in some cases has no net effect. Aside from this, a plant-based diet will also help in correction of metabolic acidosis, slow eGFR decline, and reduce CKD-related inflammation and mortality. Other potential mechanisms for diet-related kidney injury include accelerated podocyte apoptosis, leading to increased albumin excretion, oxidative stress that is brought about by potentially injurious molecules when normal detoxifying mechanisms are compromised also lead to tissue injury. Inflammation through fibrosis of tubular interstitium mediated by transforming growth factor beta-1, fibronectin, angiotensin 2, endothelin-1, and aldosterone also result in progressive nephropathy. Advanced glycation end products, which are highly reactive aldehydes, can bind to receptors or link with cell wall proteins and alter cell structure and function, ultimately leading to cell death. Increased collagen and matrix production accelerate glomerular sclerosis and exacerbate nephron scarring. Protein is responsible for a major fraction of our kidneys' workload. A low protein diet of 0.6 to 0.8 gram per kilogram ideal body weight per day will reduce amino acid oxidation and protein degradation. Protein restriction is recommended provided there is a sufficient energy intake to promote protein sparing and avoid protein energy wasting. Further protein reduction with the addition of keto acid analogs to ensure sufficient balance of essential amino acids normally brought about by animal proteins is believed to result in slower eGFR decline and lower levels of uremic toxins. More aggressive dietary protein restrictions should be made only when dialysis is not a treatment option or needs to be postponed within a reasonable amount of time. For example, in patients waiting for vascular access maturation. A higher protein intake is required of dialysis patients to manage protein catabolism and protein loss during dialysis. Low dietary protein intake among dialysis patients is associated with higher hospitalization rates and mortality risk. The 2012 KDIGO guideline for CKD recommends lower protein intake of 0.8 gram per kilogram per day in adults with or without diabetes mellitus and with eGFR of less than 30. The latest KDOQI guideline in CKD nutrition recommended a low-protein diet providing 0.55 to zero point 0.6 per kilogram per day or a very low-protein diet providing 0.28 or to 0.43 gram per kilogram per day with the additional keto acid or amino acid analog to reduce the risk of ESKD and death and to improve quality of life among metabolically stable non-diabetic CKD stage 3 to 5 patients. A higher dietary intake of 0.6 to 0.8 gram per kilogram per day was recommended for diabetic CKD stage 3 to 5 patients to maintain a stable nutritional status and to optimize glycemic control. For dialysis patients with or without diabetes mellitus, dietary protein intake of 1 to 1.2 gram per kilogram per day is recommended to maintain a stable nutritional status. Here is a summary of the numerous benefits of a plant-based, low-protein diet. Keto acid analogs of essential amino acids lack the amino group bound to the alpha carbon of an amino acid, thus can be converted to their respective amino acids without providing an additional nitrogen. Its benefits include maintenance of protein energy status without increase in nitrogen waste products, reduction of phosphorus and acid load, and decreased protein degradation. It also delays the initiation of hemodialysis or peritoneal dialysis and also potentially improves lipid profile and markers of bone metabolism. For adults with CKD without diabetes, not on dialysis, and with an eGFR of less than 20, the addition of keto analog to a very low-protein diet is recommended to meet protein requirements and help preserve kidney function. Energy requirements of patients with earlier stages of CKD may not be substantially different than for healthy adults. In adults with CKD stage 1 to 5D and post-transplantation patients who are metabolically stable, an energy intake of 25 to 35 kilocalories per kilogram body weight per day is recommended. It is important to remember that many factors influence energy expenditure, such as age, sex, level of physical activity, glycemic control, body composition, and weight status. In addition, CKD stage and presence of metabolic stressors such as concurrent illness and inflammation should also be considered. The amount of energy intake should be adequate to maintain neutral nitrogen balance, normal nutritional status, and body composition, and to prevent protein energy wasting. Patients should be monitored routinely to assess whether energy requirements are met satisfactorily. Changes in nutritional status should be treated and the energy prescription should be modified accordingly. Among dialysis patients, a slight increase in energy intake is advised due to the uremic factors that can cause insulin resistance. Low-protein diet increases the risk of protein energy wasting. Protein and calorie intake should therefore be assessed periodically. Priority should be identification and correction of the cause, including insufficient intake, inflammation, hormonal derangement, metabolic acidosis, insulin resistance, and protein loss. Factors beyond dietary intake should also be considered, including medications, knowledge, attitudes and behavior, access to food, depression, and cognitive function. Protein and energy intake should be increased until protein energy wasting improves. Excessive sodium intake is thought to exert toxic effects through mediating factors such as oxidative stress, inflammation, endothelial dysfunction, and scarring due to increased levels of transforming growth factor beta-1. KDIGO guidelines for CKD in 2012 recommended lowering salt intake to 90 millimoles or less than 2 grams per day of sodium or 5 grams sodium chloride in adults. The 2020 KDOQI guideline recommended limiting sodium intake to less than 2.3 grams per day in adults with CKD stage 3 to 5D and post-transplantation patients to reduce blood pressure, improve volume control. Low sodium intake has also been known to reduce proteinuria synergistically when given with pharmacologic interventions. Low sodium diet has also been suggested as an adjunctive lifestyle strategy to achieve a more desirable body weight and, more importantly, to delay CKD progression. Dietary intake of sodium can be measured objectively by a 24-hour or spot urine collection or by self-reporting. Let us take a look at the very high sodium content of commonly used seasonings. Consider this a friendly public service reminder that 1 tablespoon of soy sauce is already half of the daily recommended sodium intake. It is not surprising to know that in 2010, the estimated daily sodium intake of adult Filipinos was already more than twice the recommended. Potassium is widely distributed in foods ranging from fruits, vegetables, nuts, as well as dairy and meat products. Dietary potassium intake should be adjusted to maintain serum potassium within normal range among CKD stage 3 to 5B or post-transplantation patients based on individual needs and clinical judgment. There are several factors that influence potassium levels, such as medication, hydration status, acid-base status, glycemic control, adrenal function, catabolic state, and various GI disturbances such as diarrhea and vomiting. More importantly, potassium handling by the kidneys varies by disease state, and CKD stage. Compensatory mechanisms in response to increased dietary potassium intake include stimulation of distal nephron potassium excretion and increased fecal potassium loss. But these mechanisms can be lost up to a certain point. Potassium intake among early CKD patients is identical to the general population, but more advanced CKD stages of 3 to 4 are advised 2 to 4 grams of potassium intake per day. Patients at risk for hyperkalemia in the setting of advanced CKD should be monitored since kidney function may no longer be able to compensate for increased dietary potassium intake. Here are a few examples of foods with their corresponding potassium content. Calcium balance is tightly regulated by calcium absorption in the intestines, reabsorption in the kidney, and exchange from bone, which are all under the control of hormones triggered by calcium demand. Maintenance of serum calcium level in the normal range in CKD depends on several factors such as bone turnover, mineral regulating hormones, degree of kidney function, use of vitamin D analogs, and calcium intake. Serum calcium concentration decreases slightly in the very late stages of CKD. Dietary calcium of 800 to 1,000 mg per day may be adequate to maintain calcium balance in patients with CKD stages 3 to 4 who are not receiving vitamin D analogs. This is within the range of the current daily dietary calcium recommended for healthy adults. In CKD stage 5 patients, calcium intake should be adjusted considering the concurrent use of vitamin D analogs and calcimimetics to avoid hypercalcemia or calcium overload. Calcium concentration in dialysate also influences calcium levels, and in cases of hypercalcemia, a low dialysate calcium of 1.5 to 2 mg per liter should be used. Phosphorus is an essential nutrient found in most foods as a natural component or as an additive during food processing. During the early stages of CKD, physiologic adaptations are in place to avoid excessive phosphorus retention. However, phosphorus excretion can no longer be increased once the eGFR reaches less than 45. Phosphorus intake of less than 80 milligrams per day is recommended to maintain serum phosphate levels in the normal range to avoid hyperphosphatemia and avoid phosphorus accumulation. More importantly, the bioavailability of dietary phosphorus source should be considered. Plant-based food contains the organic form of phosphate, which are more nutrient dense and have higher nutritional value. They also require phytase, which has low activity in humans, and therefore the gastrointestinal tract absorption is lower at 20 to 50%. Animal-based phosphate sources are absorbed to a greater extent at around 40 to 60%. Processed foods contain the inorganic phosphorus which are completely absorbed and quickly absorbed upon ingestion. In addition, these sources also have lower nutritional value and are almost always paired with sodium and potassium additives. Potential mechanisms how high dietary phosphate intake may harm the kidneys include tubular atrophy, interstitial fibrosis, endothelial dysfunction, calcium deposition in kidneys and vessels, and reactive oxygen damage. Patients with higher phosphate levels have been found to progress faster to ESRD and also have higher mortality rates. Dietary counseling should be done not only to emphasize the amount of daily dietary phosphate intake, but also to consider its source. We should also advise patients to prepare foods at home, to slice and boil food with the water later discarded to remove approximately 50% of the phosphorus content. Patients should also be taught to read food labels and to look for phosphate additives. In the phosphorus pyramid, food types were distributed on 6 levels based on their phosphorus content, phosphorus to protein ratio, and phosphorus bioavailability. Each level is colored with corresponding recommended consumption frequency, with the highest at the base, meaning unrestricted intake, and the lowest at the top, which comprise of food to be avoided as much as possible. We reported an unusual case of a 39-year-old diabetic male who presented with epigastric pain and acute onset oliguria. He was found to have elevated serum creatinine of 12.85 from his previous of 1.68 only 3 months prior. He also had elevated BUN, potassium, uric acid, and phosphorus. Kidney biopsy revealed marked focal atrophy, tubular cell injury with transparent crystals, CAS, which stained positive for von Cosa, which is a classic finding in acute phosphate nephropathy. Kidney biopsy also showed marked focal interstitial fibrosis and fibrointimal thickening of blood vessels. This patient is a chef who, 4 days prior to his hospitalization, consumed several servings of pasta daily. The amount of phosphorus he consumed was estimated to be more than twice the recommended intake for adult men, which is around 1.5 grams per day. This case reminds us to emphasize proper dietary restrictions to patients with predisposing factors, and in this case, pre-existing chronic kidney disease. There are no specific recommendations for dietary fiber intake among adults with CKD. CKD patients often have leaky gut, leading to translocation of endotoxins and eventually inflammation. Low fiber diet is usually accompanied by elevated levels of inflammatory markers and increased risk for CKD development and progression. High fiber diet, on the other hand, promotes growth of commensal bacteria, including bifidobacterium, which strengthens the GI permeability barrier. It also facilitates stool excretion, thereby promoting urea and potassium excretion. Daily dietary fiber recommendation is at least 25 grams per day. Here are some examples of high fiber food. In adults with CKD stage 3 to 5, 2 grams per day of long-chain omega-3 polyunsaturated fatty acid was suggested to lower serum triglyceride levels. Increased intake of food rich in PUFAs was shown to delay eGFR decline over time by enhancing endothelial function and decreasing mesangial cell proliferation. In adults on maintenance hemodialysis, 1.3 to 4 grams per day of long-chain omega-3 PUFA was recommended to lower triglycerides and LDL and also to raise HDL levels. During CKD progression, requirements and utilization of nutrients change significantly, and these changes ultimately place our patients at risk for nutritional and metabolic abnormalities. CKD patients are likely to be deficient in certain micronutrients. Reasons for this include insufficient dietary intake, dietary restrictions that limit intake of vitamin-rich foods, improper absorption of vitamins, medications, and illness. Micronutrients can also be lost through dialysis. Patients at higher risk for deficiency are those with poor intake and wasting syndromes and those with malabsorption conditions. Patients on vegetarian diets are also susceptible to micronutrient deficiency. Dietary vitamin intake should be assessed periodically in CKD patients stage 3 to 5B and post-transplantation patients. Supplementation should be considered in patients with inadequate vitamin intake. For patients on dialysis with inadequate dietary intake for prolonged periods of time, Multivitamin supplementation should be considered, including water-soluble vitamins and essential trace minerals to prevent or treat micronutrient deficiencies. Vitamin D supplementation in adults with CKD should be in the form of cholecalciferol or ergocalciferol. The recommended daily intake of vitamin C for CKD patients and post-transplantation patients is at least 75 grams per day for women and 90 milligrams per day for men. Vitamins A and E are not routinely supplemented in adults on dialysis because of the potential for vitamin toxicity. If supplementation of either is warranted, excessive doses should be avoided and patients should be monitored for toxicity. In adult CKD patients, it is recommended that a dietitian or an equivalent provide medical nutrition therapy. The goals of MNT are to optimize nutritional status and minimize risk imposed by comorbid conditions and alterations in metabolism on the progression of kidney disease and on the adverse clinical outcomes. MNT should be tailored to the needs, nutritional status, and comorbid conditions of the patient. In more advanced stages of CKD, the dietitian should monitor and evaluate appetite, dietary intake, body weight changes, biochemical data, anthropometric measurements, and nutrition-focused physical findings to assess MNT effectiveness. Nutrition care includes providing nutrition assessment, interventions to delay kidney disease progression, and individualized meal plans. It should also entail follow-up on adherence and implementation. It should also address inflammation, obtain euvolemic status, contribute to the correction of electrolyte abnormalities, and assist in anemia and bone disease management. In adults with CKD stage 3 to 5D or post-transplantation patients at risk for or with protein energy wasting, a minimum of 3-month trial of oral nutritional supplement is recommended if dietary counseling alone is not adequate. In CKD stage 1 to 5D patients with long history of inadequate intake and unsuccessful dietary counseling and oral supplements, a trial of enteral tube feeding should be considered. And in patients with protein energy wasting, total parenteral nutrition for CKD stage 1 to 5 patients and intradialytic parenteral nutrition for dialysis patients should be given to improve nutritional status if oral and enteral intake is not adequate. The 2020 KDOQI guideline found that intradialytic parenteral therapy did not offer any additional benefit over oral nutritional supplementation. But patients on hemodialysis with evidence of protein energy wasting and inadequate dietary intake, patients unable to tolerate adequate oral nutrition, and patients with protein and energy requirements not met with oral and enteral feeding may benefit from it. Serum glucose, blood pressure, and volume status should be monitored closely when giving intradialytic parenteral nutrition. The ultrafiltration rate should also be adjusted accordingly to remove the extra fluid provided by the intradialytic parenteral nutrition. Health systems should place strong emphasis on CKD prevention because of its impact on patients and the community. Diet is an underused strategy by physicians in preventing the development and slowing the progression of CKD and in the management of its complications. Attention to nutrition and diet should be emphasized when CKD is first diagnosed, because this is the time period when non-pharmacologic interventions are most likely to be effective. Nutrition therapy should be consistent, individualized to each patient, and culturally sensitive. For nutrition therapy to be successful, the patient should be properly informed, have good communication with his physicians, and should have also the support of other household members. Adherence monitoring is also indispensable to ensure consistent positive outcomes. Thank you for your attention.
For the highlight of this postgraduate course, let us be inspired as we hear from Dr. Bong Javier. Please proceed to www.tiktok2021.com and click on the Distinguished Alumnus Lecture in the Plenary Session tab.